Welcome to Module 5 of the series entitled Emerging Treatments for Early Alzheimer's Disease, Efficacy, and Safety Data. My name is Dr. Mark Lagronin. I'm a geriatric psychiatrist and serve as the Senior Vice President for Behavioral Health at Miami Jewish Health in Miami, Florida. I'm also the Chief Medical Officer from Mind Institute at Miami Jewish Health, which is our Memory Disorders Center. I'm joined again by my friend and colleague, Dr. Richard Isaacson. He is the Director of the Alzheimer's Prevention Clinic and an Associate Professor of Neurology. He's also an Assistant Dean for Faculty Development at Weill Cornell Medicine and New York Presbyterian in New York City. And Dr. Isaacson, welcome so much again.
Dr. Gronin, thanks for having me and look forward to the discussion.
Absolutely. In terms of disclosures, I do some consulting for Biogen and Eli Lilly, and Dr. Isaacson does not have any disclosures for this program. The program is provided by the North American Center for Continuing Medical Education, an HMP company, and supported by an educational grant from Biogen. In the program today, we will describe future clinical uses for disease-modifying treatments for early Alzheimer's disease, and we'll summarize some of the efficacy and safety data for emerging Alzheimer's disease medication. So, as we talked about in the last module, and Dr. Isaacson really emphasized so well, there's been a lot of failures, but we've learned a lot along the way in terms of anti-amyloid immunotherapy, essentially using antibodies developed to target different forms of amyloid protein to light it up in the brain to get our own immune system brain to eat it up. So bapineuzumab was the first specific anti-amyloid antibody that went into clinical trials. Unfortunately, even though we could see evidence that it appeared to begin to mobilize amyloid protein in the brain, we didn't see any clinical benefit from it. And we began to realize with that and going into the solanezumab trials, maybe we shouldn't be looking at people getting better, but we should look at the rate of decline. Can we slow the disease process down? Now, there were 2 phase 3 double-blind placebo-controlled trials of individuals with both mild and moderate Alzheimer's disease using solanezumab, which was really the second major anti-amyloid immunotherapy. Again, the trials met neither the primary endpoints. There's a secondary analysis which showed some statistically significant slowing of cognitive decline around 30%, but unfortunately the final data analysis did not meet the primary endpoints to support sufficient efficacy. And so I would say 2 things from here. One is in early trials for both of these, there were a significant number of individuals who, as we later found out, didn't have sufficient amyloid burden in the brain. So essentially you're treating people who probably didn't have Alzheimer's disease. The other thing is that could there have been dosing issues? Were there other factors in that? Whatever, we began to see that there appears to be an ability to mobilize and get rid of amyloid protein to slow this down. We just didn't see sufficient efficacy to really move forward with either agent in those early trials.
And then we have a little bit more of somewhat of the same old story. There are additional studies of gantenerumab and crenezumab that have not shown efficacy. Now, again, there are different reasons why these may not have shown efficacy. Was it the dose? Was it the duration? Was it the right patient type? Could it have been, as we talked about a few modules ago, about maybe it may be preferentially effective in a person with one gene or another, so a precision medicine component, or maybe it's because people had more side effects in one group versus another based on genetics. So these are all very confusing, but the early studies, we had to really learn these things. There is an agent, BAN2401, that's still in active trials, phase 3 studies. And then there's aducanumab, which has shown efficacy in slowing down the rate of cognitive decline in early stage AD at higher doses when compared to placebo. And this is based on the EMERGE trial, one of 2 concurrently run phase 3 studies. And there was EMERGE and ENGAGE. And these data, the pooled data from EMERGE and ENGAGE has been submitted to the FDA for approval. And there are also several anti-tau immunotherapy protocols that are also active. So what I would say is, yes, we've had lots of failures, but we hope that this has set us up for success. However, we still need, a little bit more time to truly know how this all will shake out.
When we've done these trials, in general, they've been well tolerated, but there is one specific side effect issue that we definitely want to talk about, which is called ARIA. This stands for amyloid-related imaging abnormalities. And essentially what we've seen is that over the course of someone getting an anti-amyloid immunotherapy, if we follow sequential MRIs, sometimes we can see these emergent white matter lesions, either what's called ARIA-E, in which we see essentially vasogenic edema, so these spots of edema build up in the brain. We believe this is due to the fact that as you begin to mobilize and pull out amyloid from the brain, you're also pulling out of the vasculature, and so you can get maybe some leakiness in certain areas. We also see what's called ARIA-H, in which you see MRI abnormalities due to microhemorrhages and hemosiderosis, or the deposition of blood, which is then slowly degraded over time. Usually when people have ARIA, it's asymptomatic. The only way we typically know is just by doing the MRI and seeing it. Sometimes people can be mildly, for the most part, symptomatic. They can have headache, dizziness, confusion. We know that people who have ApoE4 are at increased risk for developing ARIA, and also individuals on higher doses of the anti-amyloid antibodies also at a higher risk. The good news is that they typically resolve. And so in a number of trials we've done, I've seen a number of individuals who had ARIA. Almost always we didn't know about it until we did the MRI. We hold treatment, it resolves, and there's the option of starting treatment again.
And on the horizon, there are other exciting drugs that may not focus specifically on tau and may not focus on amyloid, but focus on other important mechanisms. So, for example, there's T3D959, which is in clinical trials now to help regulate dysfunctional brain glucose, energy, and lipid metabolism. So this is a really important mechanism, which I really believe in. I think that whether it's this agent or something else, whether it's through, for example, lifestyle changes or drugs or whatever, I think energy metabolism specifically related to glucose is something that's very important. ALZ-801 is a prodrug. It's a form of trimiprazate, which has been studied in the past in a variety of studies, and it's designed to inhibit amyloid oligomer formation in Alzheimer's disease. And this is actually exciting because this agent is going to be used from a kind of a pharmacogenomic perspective in very specific people with a specific subset of genes. And I know Dr. Agrona and I share some patients with this kind of more rare subset. And we've had patients that have been on this agent in past iterations. And I think it's exciting that at least the field is moving in this direction towards precision medicine. And then another is a very interesting epichaperone inhibitor, which is designed really to cause degradation of aberrant proteins associated with the progression of Alzheimer's. So this is just a small snapshot. There are literally dozens and dozens more that we could cover, but I think it's exciting to realize that we're going to be having these concurrent trials along the way.
Yeah, and I think that's a good point. This is just a small subset. There's a lot going on, but it's exciting that there are things going on. And a number of latest developments that we really should mention here. Some of these emerged recently at the Alzheimer's Association International Conference. This is something really near and dear to Dr. Isaacson, a big focus on brain-healthy lifestyle factors that can provide up to 30% risk reduction over time. Just an example, one study found that individuals who were involved in 6 or more activities per month had a 30% lower rate of dementia. Definitely focusing on a lot of these lifestyle factors can make a difference. We also know that good blood pressure control has been shown to really significantly reduce risk. It's pretty interesting that in one study where they had individuals keep their blood pressure, their systolic blood pressure, below 140 or below 120, the lower group that had better blood pressure control had 19% fewer diagnoses of mild cognitive impairment and 15% fewer cases of dementia. That's a big difference. And another really interesting study showed such a really direct correlation between people who had increased bacteria in their mouth and gums due to poor oral hygiene. So, we know there's a proximity between your mouth and your gums and your brain, but who would have thought that somehow there could be a link between bad bacteria and the buildup of amyloid protein? So obviously it gives more to the notion of, brushing and flossing your teeth. And Dr. Isaacson, anything you want to add also about, dementia prevention and these lifestyle factors?
Sure. So I think, I just want to reiterate this study, the Sprint Mind trial that came out last year, just one thing, just reducing blood pressure Okay, optimizing blood pressure. And the key there is optimizing, because, some people think 140 is normal systolic. I don't necessarily agree with that. But if you take 140s over 80s and you go to the 120s over 70s for 3.5 years of treatment, that's it. Just 3.5 years of treatment, it reduced the likelihood of developing mild cognitive impairment by 19%. Like, I'm glad you have a newspaper on the slide, because it's so important. It's so important because we need to stop the presses and get this out there. The concept of prevention, we think about normal. What is a normal range, right? Well, normal range includes high normal and low normal. But then there's this concept of optimal. And if we can optimize, if we can, have optimal numbers, optimal cholesterol, optimal blood pressure, optimal blood glucose, fasting glucose, optimal diet, optimal, all these different things. The difference between, walking X number of steps versus exercising over 150 minutes a week, these are really, really striking differences to go from maintaining brain health to maybe even improving brain health. And that's some of the research that we focus on. And just last week, I had a patient a dentist, and the dentist loves when their neurologist tells them they better be flossing. So I agree with you that oral hygiene is really key. And we can go on, but individualizing preventative care and risk reduction care for people is really in one-day conjunction with disease-modifying therapies is just like how we manage diabetes. There's lifestyle changes, right? There's dietary changes. There's everything, and then we have different types of drugs. So I think the same thing is going to be for Alzheimer's disease soon enough.
It's so true. We have to get the word out on that, and we need more clinics like the one you're running up at Cornell that focus on prevention and focus on lifestyle. So thank you again for joining us for this module, and just a reminder to please complete the post-activity questions. And again, we invite you to join us for Module 6 of the series entitled Caregiver Connections, Shared Decision Making, and Patient Resources.